Good morning. Welcome to all who have joined us here today during Brain Injury Awareness Month to discuss what's at stake in concussion recovery. I'm Donna Meltzer, CEO of Brain Injury Services located in Northern Virginia. For the past year, we at BIS have been engaging in learning, questioning, gaining understanding of, and engaging in exploration about the impact of concussion on those living in Northern Virginia and beyond. Before we dive in, I want to be sure that all of our participants know that our format here is fully accessible. For those requiring closed captions, you may click on the CC icon on the bottom bar of your screen to start closed captioning. You can also select a language, view a live transcript, or adjust caption settings by clicking the caret next to the CC icon. Additionally, we know that many of you have questions today, and you will want to ask some of them of our panel. To ask questions, please click on the Q&A button at the bottom of your screen, and we will do our best to answer your questions verbally a bit later in our program or by replying in writing. After a year of study and conversations, we are here today to share with you what we have learned and to release our report, Concussion Recognition and Recovery, a Community Approach. Today, I am joined by two nationally recognized medical experts on concussion and brain injury who will share their thoughts with you. And I will engage them in discussion so that we may all learn and explore this topic together. Time permitting, we will take some of your questions. Those who registered for today's event will receive the report in your inbox, and it will be posted on our website under our concussion area as well. So please look for that later on. Before I introduce our guests, let's begin with the question of what's at stake in recovery, in recognition and recovery. How a person's concussion diagnosis and recovery are handled has wide-ranging impacts affecting millions of people each year. Troubling symptoms and impacts of concussion are often made worse or prolonged by missing the signs, minimizing or ignoring the injury, and failing to receive timely treatment, which is a key factor in recovery. As noted by the Centers for Disease Control and Prevention, the CDC, over half of people who suspect they have a concussion never get it checked. Even when a concussion is diagnosed as mild, recovery should be the top priority. However, many people feel public stigma about sharing their diagnosis and doing what's best for recovery, or they simply don't know how to best recover or where to turn for support. People experiencing a concussion are often given different directions because there is a lack of knowledge and policy guidance across sectors. If a concussion is not properly identified and supported, it can lead to adverse effects, including broader impact on an individual's mental health and well-being, limited productivity at school or work, shaping long-term earning and employment potential, stress on family relationships and other relationships key to mental health, and need for ongoing services and support. And all of these factors have long-term overarching economic and community impact and highlight the need for ongoing collaboration and discussion. So why does this matter? A year ago at BIS, as we were preparing for Brain Injury Awareness Month, we released a poll in Northern Virginia. Let's take a look at that poll. The key findings were, based on the questions we asked, that close to half, or 43% of people that we surveyed said that they would not know or are not sure they know how to protect themselves or a loved one after having a head injury or a concussion. More than half, or 53%, don't think that public schools have the awareness or knowledge needed to deal with students who suffer head injuries. More than 3/4, or 78%, said that they would be reluctant to tell their employer that they had a head injury that might limit their ability to perform their regular work duties, including reading or looking at a computer screen for an extended period of time. 2/3, or 78%, say they would be reluctant to, I'm so sorry, I just read that one. 2/3, 67%, say that sports culture has made it acceptable to ignore a concussion to be able to get back on the field. 2/3, 67%, also say that they have seen adults continue to play sports after getting hit on the head, and 57% say they've seen children resume play right after a hit. More than 70% do not know there are free services available in Northern Virginia when a person does need help after head injury. And all of these factors have long-term overarching economic and community impact and highlight the need for ongoing collaboration and support. The results of this poll led us to having deeper conversations with experts and community leaders across key sectors: employment, education, schools, sports, healthcare, technology, and the criminal justice system. We learned more from the experts in each of these sectors. We realized that we needed to convene a summit to discuss what was at stake: the well-being of individuals, families, and whole communities that suffer the impact of concussion and brain injury. The report that we are bringing forward today includes key findings and insights from stakeholder discussions and identifies opportunities for continued collaboration to improve concussion recovery across Virginia. It also contains a comprehensive set of local and national resources that are available for concussion recovery for individuals, families, healthcare providers, schools, and employers. We know that solving complex issues requires a community approach, and we stand ready to continue our efforts to foster collaboration to help create a future where concussion recovery is a top priority, and everyone affected by a brain injury has access to the care, support, and resources that they need. We went into our summit knowing that if a concussion is not properly identified and supported, it can lead to adverse effects, including students struggling in school, adults struggling in the workplace, lower self-esteem, poor mental health, and fear of recurrence of concussion. Our summit was convened in September of 2024. Our panelists were representatives across different sectors of our community. They represented the healthcare, education, sports, employment, criminal justice, and technology sectors. We have a list for you on our screen. During the summit, we heard from experts engaged in deep, small group thinking and reflection. Following our summit, we identified several key takeaways and opportunities. The first is that ongoing collaboration is needed across sectors such as medical, school, employment, education, etc. The second is that information resources need attention. We still have gaps to be filled, and materials should be tailored to specific groups such as families, healthcare providers, employment providers, human resources, schools, school personnel, and athletic leaders. Those in underserved communities and communities where English is not their first language should be prioritized for greater information in their own languages. And third, key sectors should help with information distribution and leverage it using technology and digital media. Fourth, the bottom line we all agreed on is that while information about concussion exists, we all must come together to share it and customize it to each impacted population or setting. So let me introduce our incredible panelists who have joined us today. Today we have with us Dr. Juliet Haarbauer-Krupa, adjunct faculty, Department of Pediatrics at Emory School of Medicine and health scientist on the TBI team at the CDC. I'm not going to read everything that is on this slide about Dr. Krupa, but she has quite an incredible background, and in Q&A today, she's going to share with us a lot of information about her work and her thoughts on concussion. Next slide, please. We also have with us Dr. Gregory O'Shanick, or Dr. O, as we like to call him. Dr. O is President and Medical Director of the Center for Neurorehabilitation Services and Medical Director Emeritus, Brain Injury Association of America. He is located in Richmond, Virginia, and has worked with us for many years as one of our local experts. Thank you both, Dr. Julie and Dr. O, for being with us today. I'm going to lead us through some questions and answers and use that as an opportunity for us to share a lot more information about concussion and the work that both of you have done to make our world safer and a better place. Dr. O, I am going to start with you. In our report, you state that as a healthcare provider, one of the most concerning statistics regarding concussion that haunts you, and I love you use that word, it haunts you, is that 50% of people with brain injury don't get them checked out. Many people don't realize that concussion is a form of brain injury. As a medical professional, how does this make you feel? And how do you talk to your patients or others you know about this important need for getting any concussion checked out?
There we go. Now I'm unmuted. Thank you for letting me be a part of this. No, you're right. Both as a clinician, but also as a father and a grandfather and a member of the community. I have coached youth sports. I have been a part of monitoring and helping out with youth sports in terms of medical support, and watching youths get injured in various types of competitive sports. And the sad fact is that many times it is clear that children, adults, others get concussed in various mechanisms. And simply it is overlooked. Simply it is not considered as being relevant in terms of their overall injury. I've had physician neighbors who have fallen off ladders while trying to do things in their house, hitting the ground. People go and look at their shoulders, they look at their elbows, they look at their knees. Never once do they consider that there is any type of concussive injury. That is absolutely scandalous. And it's only because I'm a very vocal neighbor that I inquire and say, hey, what's going on? How are you doing? Are you having headaches, et cetera? And following up with these individuals, that it gets addressed. That is, I don't want to say criminal, but dadgum, that's a major oversight. And what then happens is a cavalier attitude. Rub dirt in it. You're going to get better. Just shake it off. And quite the contrary. If somebody had a sprain of that nature in their ankle, they wouldn't be told just to go ahead and run on it. And so the implications short-term for management and long-term for vulnerability to future issues and future injury and lowering the threshold for future injury are huge. So it is absolutely a non-starter for me that people overlook it. Unfortunately, part of the reason it gets overlooked is that the ability for people then to get care subsequent for it, and I hope we get into this later on, is quite difficult. It's much easier to get your physical therapies than it is to get cognitive therapies. It's much easier to get some sort of a balance therapy or vestibulopathy treatment than it is to get attention for your attention and concentration, or even your mood issue after a TBI. And so it really is a discriminatory issue in that regard.
Just a quick follow-up to that, Dr. O. When you speak with these people who have had a concussion, do you feel like they understand that a concussion is brain injury? It could even be TBI, which I think most people recognize as very serious.
So again, I want to discriminate. At the time of the injury, most people are still a little confused. And so quite honestly, they don't have full capacity to understand it and comprehend it at that point. You talk to their family members and you say, you know, how is your person behaving? They recognize that there's something different. They don't know why. Is it the shock of an injury? Is it the fear? Whatever. People, I think, are afraid to acknowledge that there is an injury. In part, it relates to maybe an oversell of things like chronic traumatic encephalopathy. And everybody gets concerned that, oh, if I have too many of these, I'm going to be destined to have that. And so we're just going to turn a blind eye and we're not going to pay attention to it. So I think there's a bit of a concern in that regard. But I think in many situations, people try to deny and try to minimize.
Thank you. Thanks for sharing that. Dr. Julie, I know you've done some incredible work on a program called the Heads Up campaign. Can you talk to us about that? I believe that it is primarily for children who experience concussion. Is that right?
Yes, thank you. And anybody who's interested can go to www.cdc.gov/heads up. It's called Heads Up. And there's a lot of information there. And thank you for mentioning that, Donna, because we have online free trainings for coaches, physicians, teachers, parents. We have forms for parents to take back to their doctors. So if you go to the doctor, there's a form you can take. We have discharge forms. We have return to school forms. And there's a lot of information. There is a little bit for young adults. So there's information on signs of a concussion. But I urge everyone, it's all free. Everything is free at the CDC website. So it's a great way to get information on concussion.
Thank you so much for sharing that. Dr. Julie, you were quoted in our summit as saying, TBI is not just an event and you stop taking care of it once it's diagnosed. It affects how the brain works and its impacts on development. Can you talk a little bit more about that development process and once somebody has had concussion, TBI, how they have to think about this as something that could impact throughout life, meaning you might have had a concussion early in life as a child.
Mm-hmm. Mm-hmm.
Sometimes things happen later. We talk about brain injury as dynamic. It's not just something that happens at one time in life, but it might be the key to something that happens later. What made you make that statement and what can you share with us about that?
Oh, thank you very much. I've been in the field for close to 40 years. And when I first started, there was zero research on children. And we wrote the first book called Head Injury Rehab Children and Adolescents by looking at child development. However, since that time, because there's more imaging, there's more studies, we've learned that a brain injury can really impact kids over time. And sometimes, you know, this is an unexpected event, most likely to kids who've been developing. But then they have this event and the symptoms may not be clear immediately, or the effects. It may be if they had it when they were 5, when they're in 3rd grade, when reading becomes more difficult, that's when it may become apparent. Or in adolescence, it may become apparent. So that's what we're learning based on some research looking at children who have a history of brain injury. And we know too that children may demonstrate different symptoms at a younger age, say younger than 5, because they don't necessarily report their symptoms. It's by parent observation. So we're learning more from research, from imaging, from reports, that this can have a lifelong effect for children who have a concussion or brain injury.
Thank you. That's really important information. I'm glad that you shared that with our listeners and viewers here today. Dr. O, in Northern Virginia and many other areas, of course, as well, Language access is key to understanding concussion and what to do when it happens to you or to somebody else you know. At BIS, we are working to make information available in multiple languages for everyone to be able to understand. In your role as a medical provider, what do you see as important in language and ability to access information about concussion and brain injury? What do your patients and their families or others in their circle often ask you? What do they need to know?
Sure. And by that, are we referring mainly to cross-cultural kinds of issues in that?
We are, although, feel free to share what you see in your practice on a regular basis. Is it primarily the needs that maybe families who come from different cultures, different backgrounds, different languages may have different needs from those who might be local to the area, have been here long, or maybe there's an intersection? Just share what you hear and see in your practice with us.
So I think, as you've said, Donna, there's multiple layers. The most obvious is, we have a number of different cultures, a number of different languages of individuals here in the Richmond area. A large Hispanic population, a large Asian population, individuals from other cultures, and it becomes difficult in terms of doing cognitive examinations and discussing with family members the nature of the problems of memory, of forgetfulness, of attention and concentration, and word finding difficulties in ways that are meaningful for me as a non-speaker of those languages. Can use families to some degree, but to some degree there is a hesitation to be identified as having a problem, to be identified as being deficient in some ways, which makes it more problematic. That can be overcome with the use of interpreters. It can be overcome with the use of some of the language apps that are available, but you can't get the fluency component. You can't get the handle on word finding. And here I am talking to Dr. Julie's background here as a speech pathologist, but I'm married to a speech pathologist, so I guess I get a little bit of latitude. So it's, you lose some of the issue in terms of cadence. You can't pick up on the melodic issue, the prosody, the intonation, the inflection. You can pick up on the hesitation, etc. We have here in the office, we've translated all of our handouts in terms of Spanish so that family members can read it, etc. That assumes that they are literate and that they can read, which for some of our folks that have come to the United States is not always a correct assumption. So we need to find other audio resources for them. And embarrassingly, we have not done that to a degree that has been adequate. So from that standpoint, it creates an issue. The bigger problem, I think, exists in other practices where the physician or the medical provider only gets 10 to 15 minutes at most of face time. And, we've got the luxury of having a minimum of 30 minutes with a patient. Most times we can block off 60. So we can figure out ways of pantomiming or doing things to get the information. But if you've only got a 15-minute encounter, it makes it extremely difficult to get any kind of accurate information in that brief period of time, especially if there's no hard, quote unquote, neurologic signs. There's not an abnormal reflex. There's not an abnormal, facial droop or something of that nature. And these people can be discounted quite easily and overlooked for the damage that they have.
I think what I'm hearing here is also a recommendation for organizations like BIS and many others, not just in Virginia, but well beyond, if we have anybody here who is connected to other states, that we also have a lot of work to do in terms of helping individuals who don't have English proficiency to understand what the terminology is about and how to really work best with their medical provider, to perhaps share more information about, don't go into the appointment alone. Bring somebody with you who can take notes for you, translate for you. Maybe we need to get some more local, what I call community brokers, and help spread the word in their own communities.
The other point of that, though, Donna, is many providers don't allow somebody to come into the exam room with them, because that 15-minute efficiency, if you bring somebody else in, it may slow the process down. So there has to be somebody with assertive advocacy that can do that. And there has to be a mechanism by which to make that a mission critical part of this. And just as you have navigators in oncology services to help the patient navigate through the system, we need to develop a similar form of navigator system for our patients as well.
These are excellent recommendations for more work that we need to do around concussion and brain injury. Thank you for that. Dr. Julie, I want to go back to, in the heads up information, you were talking about how it's so geared for young people. The biggest question that I think comes up around children is really with parents after a concussion has happened. How do they know when it should be safe for their child to go back to school? And if they think something is or isn't safe, or their child is or isn't ready, they might end up butting heads with the school that is saying, it's time to come back. How do you advise parents on how to work around this?
Oh, that's a great question. And, I want to point out this is an unexpected event for parents, and they often don't have education to understand what the effects are, the importance of seeking care. So we're working on that by trying to get information out to parent groups and other parents, and Brain Injury Association of America, and you all are doing a good job with that too. But they may not always understand that this is an issue. And so when they go to the doctor, the medical community may not understand what needs to go to school. It's like a complex situation. Many schools, there's several states that have concussion return to school programs. And frankly, we thank the athletic community because they are the ones that brought concussion to prominence. All 50 states have return to sports. Return to school is a different matter, but for children of school age, that's covered under IDEA. So technically, if a parent says to the teacher, my child had a concussion, they need to be checked. But parents don't always know to report to schools. We're working on that. That's very important that there's communication between the medical community and the schools. And teachers are often very observant that a child's behavior is different. And what I've learned from my research is children may not test severely enough to qualify for services, but as many parents say, their behavior is different. They're not the same with learning. And so that's why sometimes it's difficult for schools to understand, because the child may be testing fine. If they return to school, they may be fine. Now, how fast to return to school? It used to be that, we would say you should stay home for a long time, yada, yada. Now there's more research coming out that says getting back to school, not necessarily sports, but school, may help your recovery. So it's good to take a rest, but parents need to work with their medical community to better understand when their child's ready to go back to school.
While we're on that topic, I was just looking in the Q&A section, and I see a question that I think is really pertinent here. It says, children with medical diagnoses are able to be considered for accommodations under Section 504.
Yes.
Do you feel that children should be considered for special education services? And do most physicians provide information for school teams to consider when it comes to head injury?
That's a great question. And yes, I wrote an article several years ago with colleagues of every specialty looking at models of care for children. And what we learned, and I think this is still true now, there's such variation in healthcare to school communication across the country. And I think people who go to Dr. O's clinic get good information. That's an example of a really strong clinic. But people who live in rural areas that may just have urgent care, they may not have information because they don't see a lot of children. So it's important to get information from physicians about their child's symptoms and follow how their child is feeling and doing at school. So it's really important for the parents, the healthcare community, and the teachers to be communicating.
Thank you so much for that incredible response. I appreciate that. While we're on this topic of when is it safe, Dr. O, you obviously, have your patients, I'm sure, asking similar questions, right? Particularly adults asking when should I go back to work, or if I'm going, or when I'm going back to work, what do I need to do differently? Because I have maybe still some symptoms, or maybe think I'm okay, but maybe staring at a screen all day isn't such a great idea, and I work in front of a computer all day. How do you advise?
Again, to echo what Dr. Julie just said, the current thinking is after 48 hours of rest, then you get the person back into a normal environment, especially vital for kids, teenagers, where the social isolation is such a major factor in increasing the psychiatric, the psychosocial behavioral issues. It's massive. The whole issue of screen time, of how much screen time and when. Again, there is a lot of debate in terms of that relative to a week, 2 weeks, et cetera. How much do you restrict it? Now, in an adult where you've got their eyes that are working in front of a computer screen all day, and they've got very subtle dysfunction of ocular motor, of either eye tracking or of moving their eyes from word to word to word, what's called saccades, that can critically trigger headaches. It can critically trigger problems with another cascade of headache symptoms, and it reduces the mental efficiency of the individual. If somebody is in a mission critical situation, there are some strategies that we used back before the days of having neuro-optometrists, of alternate patching eyes, but that's not a good solution for many people long term. But neuro-optometrists and other eye specialists, occupational therapists, can be brought in to assist in that. And many times it takes a letter from the physician asking for accommodations, that the individual can have restricted time, or can have blue filters put on the screen, or can have other types of things, adjustments done under reasonable accommodations through the ADA. So there are things that we can do. The other thing that we really learned during COVID, during the isolation and people working from home, there's a tremendous amount of cognitive energy that is used up in commuting. The basic issue of driving from your home to your place of work, finding a parking space, then navigating up to your office uses a ton of energy. And so before you even sit down at your workplace, you've already expended X amount. So many times the ability to have somebody work from home assists them in being able to function at a quicker pace and to get back to their work, if that's in fact able to be done, and then to transition them from telecommuting to back into the office.
Thank you for sharing that. And thank you for that very important reminder about accommodations. Those exist in school systems for children, and they exist in the workplace for adults. One of our panelists back at our summit last September was Bryna Helfer, who is with the Federal Office on Disability Employment, and she shared some excellent resources, which are, of course, part of our report as well. Dr. O, I can't help but ask you to bring up something that you brought up during the summit, because we have people with us here today who are not part of our summit. And that was something quite frightening that you saw going on in society that you wanted to address. And that is a topic of something called power slapping. Can you share with our folks here today what that is and why it is so scary?
Yes. Power slapping is an exercise in creating concussions in another human being by having the individual stand in front of you with standing face to face, and the individual who is the quote opponent is allowed to take their arm and full force smack you on the side of the face with a flat hand. The defender is not allowed to, that's an inappropriate word, because they're not allowed to defend themselves. They just have to stand there and accept that impact, the blunt force trauma to their face and head. The goal of this is to render the person unconscious, dazed, confused, knock them to the ground. That is the only purpose of this. And it is a voyeuristic, sadistic, experience. I'm not even going to call it a sport that has begun to take hold. It's been licensed as a quote sport in several states, unfortunately. The sad part about this is it has filtered down into our school system, where middle schools in Northern Virginia, in the Richmond area, we have children that are engaging in this practice behind the school, in bathrooms, where they post sentries by the door so that the teachers and other folks can't come in and discover it. But this is happening right now. And it's absolutely scary, absolutely abhorrent, and needs to be stopped.
Thank you for sharing that. I want to turn to a couple of great questions that are in our Q&A that have come in from our audience. The first from Kelly is, how do we get our loved one to recognize the limitations of their injury, especially an adult child? We have let our child fail, but the lesson isn't learned. Of course, it's the parents' fault for saying what they can or cannot do. Love to hear responses from both of you on that question, if you can.
I just had this discussion with somebody yesterday in my clinic. There's actually, multiple levels of reasons for that. Part of it is the behavior of normal adolescents to externalize things. It's not me that's doing it, it's somebody else external to me. Part of it is the psychological defense of denial, that the anxiety over things being wrong is too overwhelming. And so you have to exclude and deny that there's anything wrong, especially as a young adult where you're trying to fit in with your peers. And that is more important than the opinion of your parents or your family. That is mission critical. And the other part is a neurological issue. We know that injuries that involve the right frontal region of the brain result in a lack of awareness of one's types of deficits, what is termed anosognosia. You literally don't know. You can't see it. So if I'm arguing with my wife, who's a speech pathologist and always wins, all of a sudden that light bulb goes off and it's like, she's right. That's the part of the brain that just went off. It's that awareness. With anosognosia, that light bulb doesn't go off. And so the issue there becomes for these people that they truly don't see that they're doing anything wrong. It truly does become externalized. And it is a neurologic issue that is important to recognize, that you can't do psychotherapy. You can't convince or counsel somebody out of that part.
Thank you. Julie, did you have any thing you would like to add
Yeah.
to?
Yes, I agree with everything Dr. O said, but one of the things I've learned over time is individuals living with brain injury may not understand their symptoms, especially kids, until something severe happens, like they go from making A's to making F's at school, or they lose their job, or they're kicked out of something. I think, and we don't want those things to happen. We want to try to prevent them, which is why sometimes parents are so involved, because they don't want that to happen. But honestly, from my observation, sometimes that's what lets people see that they've really changed since their injury.
Natural consequences.
Natural consequences. Yes.
Thank you both for that. One final question from our audience. Virginia, as we know, has, I think it's the highest per capita number of veterans living in the state, which means we serve a lot of veterans with head injury. So Larry asked, is there any special treatment or protocols for treating veterans? Who'd like to start?
Well, I could say by looking at Veteran Affairs and the Department of Defense website, I believe they have information on that. It's very important. What's really nice is both these agencies are beginning to not only recognize brain injury from being in conflict, but blast injuries, which is also a big deal. So there's increased awareness, and hopefully people can get care in those systems. Dr. O, you may have more to add about that.
Sure. National Academy of Sciences just convened a group of experts to synthesize clinical practice guidelines. And among the ones they used were the ones from the VA, as well as the American College of Emergency Physicians and several others. It stands out, the VA do stand out as one of the more comprehensive evaluations and instruments. One of the specific difficulties, though, with veterans is that we know that the injuries and the exposures that they have are more than just blast. They're more than just concussive injuries. They're also exposed to volatile inhalants and toxic fumes. They're exposed in barracks and in vessels that they're in to potential carbon monoxide. They're exposed to other types of solvents. They're exposed to other types of things that molds and things of that nature that also play a role in terms of brain vulnerability. And so all of these things coalesce and create an increased vulnerability that have to be accounted for. Then you've got the additional burden of post-traumatic stress disorder and the cumulative effect of not only the resilience that we're trying to see and instill in our warfighters, but also the fact that when your frontal lobes are disproportionately affected, that your ability to contain that traumatic experience is compromised, and you then have more troubles.
Thank you. Any final comments from either one of you, final statements, something that you would like to share with our listeners today?
Julie?
Well, go ahead, Dr. O, then I'll speak.
First.
Oh, thank you. Well, I just want to say to everybody, we need to take care of these people. So we need to make sure they get care, they're monitored over time, and that they're doing what they want to do in life. That's my point.
I would like to paraphrase an older brain injury medicine neurology physician that said that no injury is too severe to despair, and none is too minor to overlook. To consider all of these, and we need to take them seriously and look both at the micro and at the macro level at how this impacts them as an individual, how it impacts them in the family system, how it impacts them in the community, because these are lives and productivity that we need to continue to invest in and not just throw to the side.
Well said, both of you. Thank you so much for being with us today, sharing your expertise and your experience in your work and your practices. We're so grateful for all that you have shared. For our audience, thank you for attending this session today. I hope that you were able to listen and to learn. We still have a long way to go. While we have had a summit and we have a report that is going to be released right after this session ends, it should be landing in your inbox. We know we have more work to do in convening our communities and looking at things like how AI and technology will advance so much of the research and the day-to-day work that we do, and how we can hopefully diagnose people sooner rather than later, which can perhaps lead to better outcomes for long-term health. We will continue to be working with schools, with the sports industry, with our trusted physicians, with our employment sector, and with the technology sector as we move along to make sure that we can support those in Northern Virginia and those beyond to address concussion, TBI, any type of head injury for the best outcomes for themselves and for their family members. Again, thank you all for being with us today. Take care.